My name is Anthony Gill. I'm a Senior Staff Specialist Anatomical Pathologist at Royal North Shore Hospital in Sydney and Associate Professor of Pathology at University of Sydney. Whereas an anatomical pathologist diagnostically, I spend most of my time looking at endocrine pathology and gastrointestinal pathology, including pancreatic pathology. And then in my research world, a lot of time looking at genomic testing of malignancies and how they predict the outcome and response to treatment. There are many challenges, and they're both technical as well as regulatory. I think the technical challenge is how do we deal with the immense amount of data that you receive when you sequence not just a patient's genome, but the genome of all the malignant cells in a patient. Cancer isn't just one set of cells, it's like a swarm of different clones of malignancies all competing with each other, and the body's defences and the treatment that you give the patient to see if they become the dominant clone and overtake the patient. And the amount of data, when there's 3 billion base pairs in the human genome, the amount of data in sequencing thousands and thousands of different clones of cancer in one patient can be daunting. With that daunting data, it can be hard to even transmit the data from one place to another, much less interpret it or summarise it in a way that's meaningful in the individual clinical setting. I think the other challenge is regulatory, that healthcare system is highly regulated, as it should be, because healthcare is so important, but the technologies are emerging so much faster than the regulatory viewpoints, regulatory statuses are keeping up. So we see difficulties getting research projects through ethics committees. We see difficulties even understanding our responsibilities when patients want to know the results of meaningful tests that are performed, but when we don't know whether a test result is meaningful or not, we don't know if it is meaningful, we don't know how meaningful it is. It's very hard to know how much we know, much less how much we should feed back to people when we're uncertain. I wish I knew a simple answer. I think we have no option but to try our best and almost by trial and error work out what things don't work and what things do work. We feel a bit like we're trained to drive a push bike and someone's given us a super motorbike trying to navigate with our sort of old-fashioned skill set on a new piece of equipment. I think genomic technology is so much advanced of that. I think integration of advanced molecular testing and molecular results into big data from patient care can go a long way. And how we quantify the patient care data, it raises similar problems to how we quantify the genomic data from the patients with cancers. There's so many different data points in there. And I think there's a bit of synergy between sort of the IT systems required to analyse one as to analyse another. And the other thing is that when everyone wants the result so quickly, how do we present results in a time frame where they're clinically useful before diseases progresses, at a time when treatment can be tailored to the patient, but at the same time be confident that we have the right result, and it can be challenged balancing the needs for a rapid result with a correct result. Yeah, well, I think firstly, pathology's always been sort of a backroom part of medicine, and it's lower status and less recognition. Patients with cancer, they see their surgeons or their oncologists, and they seek a lot more information from them and historically from them. I think in the area of personalised medicine and direct-to-consumer marketing of pathology tests, particularly in the field of cancer, there's a lot more emphasis on the role of cancer and personalised medicine in plotting treatments and plotting the outcome of patients. So I think that pathology itself can be more high profile. At the same time, I think that we're going to see more ownership of the pathology results by the patients themselves. So there are various models put forward that just, in the same way people track down their own family tree and put it on the internet, and other people interested in looking at their family tree can use that data for themselves. I think we will see more consumer-led, sort of wiki-led uploading of results. So we look at big genome data in cancers. I think that there'll be a move for the patients themselves to want their genomic data to be made widely available for other patients to see and for them to see other patients' data. and also for that link to their clinical data and demographic data and data which will help inform treatment decisions. And I think that symbiosis where patients will both be happy to share their data as long as they can share other people's data will be more led by the patients wanting a better outcome than the regulatory authorities or the doctors who will have concerns about confidentiality and custodianship, which is hard for them to address, where it's easy for a patient. When it's their data, they can easily sign up to allow their data to be widely disseminated. And I think that sort of internet-based open access to patients' data will be something that we'll see in a model not dissimilar to social media, but social media for cancer patients with their cancer genomes and their treatment information. Yeah, I think that there will be models where you'll see, I'm aware of some proposed models for a social media, sort of a Facebook of cancer, where people will not only support each other and send social reports of how they're dealing with complications and the issues that it brings up, but they'll also share big data. And I think that might be a way that industry who have better abilities to analyse big data than healthcare providers might see an outcome where they can get a return from investing in better responses and better analysis of the data.